Glaucoma is a group of eye diseases that can cause vision loss and blindness by damaging the nerve in the back of your eye called the optic nerve. Learn more about glaucoma. If glaucoma medicines and laser treatment haven't helped to treat your glaucoma, your doctor may recommend surgery. Surgery can't cure glaucoma or undo vision loss, but it can help protect your vision and stop it from getting worse. There are a few different types of surgery for glaucoma that can help lower the pressure in your eye. Trabeculectomia, glaucoma implant surgery, minimally invasive glaucoma surgery, AMEGSA. If you need glaucoma surgery in both eyes, your doctor will only do surgery on one eye at a time. What is trabeculectomy? This type of surgery is usually used to treat open-angle glaucoma. It's done in a hospital and usually takes less than an hour. The surgeon will create a tiny opening in the top of your eye. The opening will be under your eyelid, where no one will see it. This opening allows extra fluid in your eye to drain away, lowering pressure in your eye. Usually, you'll be awake during this surgery, but you'll get numbing medicine and medicine to help you relax. You can usually go home the same day, but you'll need someone to drive you home. What is glaucoma implant surgery? This type of surgery is used to treat several types of glaucoma, including congenital glaucoma, neovascular glaucoma, and glaucoma caused by an injury. It's done in a hospital and usually takes 1 to 2 hours. In this operation, the surgeon implants a tiny tube or shunt onto the white part of your eye. The tube helps extra fluid drain out of your eye, lowering your eye pressure. Usually, you'll be awake during this surgery, but you'll get numbing medicine and medicine to help you relax. You can usually go home the same day, but you'll need someone to drive you home. What is minimally invasive glaucoma surgery, AMEGSA? If you have mild glaucoma, your doctor may recommend a new approach called minimally invasive glaucoma surgery, AMEGSA. This also lowers eye pressure, but it has fewer risks and side effects and helps you recover faster. There are different types of MIGS, so ask your eye doctor about whether MIGS may be an option for you. What happens after surgery? Your doctor will prescribe eye drops to help prevent swelling and infections, and you'll need to use them for several weeks. These eye drops are different from other glaucoma eye drops you may already use. Get tips for using eye drops. While you recover, you may need to avoid some activities for 2 to 4 weeks, like lifting anything heavy. You will also need checkups with your doctor to make sure your eye is healing well. Will I need surgery again? For some people, the benefits of surgery last a long time. For others, the opening in the eye begins to close up and they need surgery again. You will need regular checkups with your doctor to test your eye pressure. That way, your doctor will be able to act fast if you need more treatment. Research shows that trabeculectomy can lower eye pressure in about 7 out of 10 people. It may work best in people who haven't had an eye injury or another eye surgery. What are the side effects of surgery for glaucoma? Glaucoma surgery can have side effects, just like any operation. For example, your eye may be swollen and sore for a while. Other possible risks of glaucoma surgery include a cataract, problems with the cornea, the clear front layer of your eye, eye pressure that's too low, vision loss. Talk over the pros and cons of surgery with your doctor. Together, you can make a treatment plan that's right for you. Blepharoplasty plays a vital role in facial rejuvenation, with direct aesthetic relation to the brow and the cheek. Upper and lower eyelid blepharoplasty are indicated for the treatment of excess skin and orbital fat. Preoperative evaluation should include a thorough medical and ophthalmic history, along with a detailed cutaneous and eye examination. Symptoms of pre-existing dry eye should be elicited preoperatively, as they directly correlate with postoperative complications. Physical examination should take into account brow position, eyelid ptosis, lower eyelid position, and cheek projection. Blepharoplasty can be performed by keywords of blepharoplasty, fat excision, fat repositioning. Go-to introduction. Ophthalmic plastic surgery primarily deals with disorders of the eyelid, cowrieman apparatus, orbit, and preocular cosmetic surgery. In the past, The average ophthalmic plastic surgeon focused mainly on the functional disciplines, with few surgeons showing any interest in cosmetic surgery. This trend is gradually changing, and today, most ophthalmic plastic surgeons perform cosmetic surgeries and many specialize in this area of practice. The eye is an important component of facial aesthetics, and blepharophylaxis can play a vital positive role in facial harmony and the perception of aging. Blepharophylaxis is one of the most commonly performed facial cosmetic procedures. Symptoms such as tired-looking eyes, excess skin, droopy eyelids, or circles around the eyes may benefit from blepharophylaxis when it can also be combined with other facial and skin rejuvenation procedures such as brow or mid-face lift, lasers, or chemical skin resurfacing. To this article aims to give an overview of upper and lower eyelid blepharophylaxis techniques. Go to preoperative evaluation. Preoperative patient evaluation for blepharophylaxis should document medical and ophthalmologic history such as chronic systemic diseases and medications. Ophthalmologic history should be obtained, including vision, corrective lenses, trauma, glaucoma, allergic reactions, excess tearing, and dry eyes. No cosmetic surgery of the periorbital region should be performed for a minimum of 6 months following corneal refractory surgery. Schirmer's test should be considered if there is history of dry eye. In addition to complete eye examination, the evaluation of the periorbital area should take into account skin quality and quantity, underlying three-dimensional soft tissue contours, and the bony skeletal support. Assessment of the upper eyelid. Upper eyelid dermatocolysis is the loss of elasticity and support in the skin. This can create a fold of excess upper eyelid skin, which can impair the function of the eye, including superolateral visual field obstruction. Figure 1, top left and right. Evaluation of preseptal and eyebrow fat pads is important in redefining the superior sulcus. Assessment of patients' old photographs aids the surgeon in restoring the youthful look. Upper eyelid ptosis should also be noted, since it can be corrected simultaneously. Assessment of the lower eyelid. Lower eyelids should be assessed for skin excess and fat herniation, which typically presents as medial, central, and lateral fat pads. Lower eyelid fat becomes more prominent in upgaze and less prominent in downgaze. Figure 1, bottom left and right. Downward displacement of the lateral canthus can result from dysinsertion, laxity, or the presence of a prominent eye. Figure 1, top right. Lower lid distraction test can determine the degree of laxity and guide lower eyelid canthal repositioning. The posterior displacement of the orbital rim in relation to the anterior cornea and lower lid margin, a negative vector, should be noted. Preoperative assessment of the eyebrow. Bryotosis is assessed by evaluating the position of the eyebrow in relation to the superior orbital rim. Asymmetry in the upper and lower eyelids and brow position is common and should be recognized and addressed individually. Go to anesthesia. Blepharophylaxis may be performed under either local or general anesthesia depending upon the surgical plan, patient and surgeon preference, and need for concomitant operations. A simple upper or lower eyelid blepharophylaxis where only skin or fat is excised can be performed under local anesthesia. Other more invasive procedures, such as lower blepharophylaxis combined with fat repositioning, mid-face lift, or endoscopic brow lift may need intravenous sedation or general anesthesia. Go to upper eyelid blepharophylaxis. Preoperative marking. Preoperative markings should be made with the patient sitting upright in neutral gaze with the brow properly positioned. The eyelid crease is situated above the ciliary margin approximately 8 to 9 min women and 7 to 8 min men. The lower limit of excision should be along the eyelid crease, and the lateral extent of the marking should be limited by an imaginary line joining the lateral end of the brow to the lateral canthus. Figure 2, top right. The extent of excision should be at least 10 from the inferior border of the brow, making a pattern of skin excision as shown in the figure 2. The skin pinch test can confirm the preoperative markings. A minimum of surgical technique. The upper lids should be injected superficially with lidocaine with 100,000 epinephrine using a 27 to 30 gauge needle. Figure 2, bottom left. Skin incision can be made either with a no 15 barred Parker blade or the upper tip of radiofresh monopolar cautery. Figure 2, bottom right. Conservative fat excision can be performed as part of upper lid blepharophylaxy figure 3, top right. There are two fat compartments, medial and central, that can be accessed through small incisions in the septum, teased out and resected using radiofresh monopolar tip. Of the medial and central fat, only the retroorbicularis oculi fat can be accessed beneath the lateral orbicularis overlying the superior orbital rim. Resection has been described to help decrease heaviness of the upper lid and lateral brow. The subbrow fat pad can be repositioned during wound closure with use of eyelid suspension sutures. This can be done with 2 to 3 absorbable sutures that incorporate the orbicularies from the lower and upper edge of the incision along with the superlateral arcus marginalis figure 3, bottom left. These sutures might result in early overcorrection of the upper eyelid leading to lacothumpos, which improves within days after the surgery. The postoperative care. Postoperativity. Patients should be advised to use ice packs on the surgical site for 3 days to minimize postoperative swelling, and topical ciprofloxacin ophthalmic ointment on the incision sites for 2 weeks. Non-absorbable sutures, if used, can be removed after 1 week. Complications. Possible complications include upper eyelid retraction with scleral show from anterior nullary inadequacy, lacothumpos, acquired diplopia, and corneal exposure. The most common complication of cosmetic surgery is failure to meet the patient's expectations. This can be avoided by preoperative counseling and identifying reasonable expectations. Go to lower eyelid blepharophylaxy. Aging can lead to a number of aesthetic changes in the lower eyelid, including skin laxity or excess, orbital septum laxity, orbicularis laxity or hypertrophy, herniation of the orbital fat, canthal laxity, malofestounds, crow's feet, and preocular wrinkles. For common complaints include eyelid bags, circles under the eye, wrinkles around the eye, or a tired look. Anatomically, relaxation of the orbital septum, orbicularis muscle, and skin can cause protrusion of introitable fat leading to eyelid bags figure 1 top right. Typical preirritable hollows have a distinct anatomic basis. That the traditional procedure in lower eyelid blepharophylaxy was to remove the pseudo-herniated fat via skin incision. A recent, more conservative approach includes repositioning of the herniated fat in cases of tear trough deformity into the superior space. Both these approaches may be accompanied by strengthening procedures for the attenuated septum or septorphany and tightening of the orbicularis muscle and skin. 6 to focused copper laser irradiation of the undersurface of the orbicularis results in persistent shortening and tightening of the muscle tissue. 4. The approach to the lower eyelid remains a controversial issue within plastic surgery. The transconstantin approach had reduced chances of eyelid retraction, scleral show, and postoperative atropine compared to other methods. 7-9 Some surgeons prefer a transcontinuous approach in patients who have hypertrophy of the orbicularis oculi muscle and therefore require muscle excision. 10. For transconstantin lower lid blepharophylaxy, the inferior fornix, eyelid skin, and lateral canthus are anesthetized with one lidocaine containing 100,000 epinephrine figure 5, top left. Surgery is performed through an incision made for 6, below the lid margin through the conjunctiva and lower eyelid retractors figure 5, top right. This can be done by sharp dissection with scissors, radiofresh monopolar cautery, or laser. Gentle pressure on the eyeball prolapses the fat compartments and aids in identification of the medial, central, and lateral fat pads. Conservative fat. Some surgeons perform lateral canthopathies along with lower eyelid blepharophylaxy. It eliminates unnecessary skin resection and is believed to restore tone and youthful contour of the lower eyelid. 41,112. Wrinkles and excessive vertical skin can be dealt with by skin resurfacing techniques, such as chemical peeling and Cotwar or Opthalmic laser resurfacing. These techniques are applicable only to patients with Fitzpatrick skin type I2E. Patients with darker skin are at risk of pigmentary changes, hence these can be managed with surgical excision by the pinch technique, as seen below. Transcontinuous lower lid blepharophylaxy. The skin pinch technique is ideal for skin laxity alone. With no fat prolapse. 13 It is approached through a subciliary incision with the skin elevated off the orbicularis. The amount of skin to be resected can be estimated with a skin pinch between forceps. Redundant skin can be removed conservatively and redraped without disturbing the underlying orbicularies. The more aggressive skin muscle flap method is also approached through a subciliary incision, undermining the skin and orbicularies. The pretarsal orbicularies fibers should remain intact, and the skin and perceptal orbicularies are elevated as one flap. Dissection can be continued along the orbital septum to the level of the orbital rim. Parietal fat is approached through small incisions in the septum. Orbicularies, muscle fibers, and skin can be excised at closure. However, damage to the orbicularies may lead to lower lid malposition and orbicularies denervation. Complications. Severe complications such as visual loss from orbital hemorrhage, orbital injection, or posterior optic nerve infarction are extremely rare, but have been described. 14 other possible complications are lower eyelid retraction with scleral show, lacothumpos, corneal exposure, and acquired strabismus. Other methods suggested to correct hair trough deformity include orbital fat removal, fat injections or grafts, and alloplastic cheek implants. In general, transconjunctive fat repositioning results in leveling of the tear trough deformity, a smooth contour of the lower eyelid, and high patient satisfaction. 20. Complications. Complications include persistence of dark circles, temporary skin irregularities from fat and edema, fat granulomas, restricted ocular motility, or new-onset diplopia. 21. Go-to combination therapy. Variations to these standard blepharophylaxis approaches are numerous, and often a combination therapy is needed based on patient findings. 22. Fillers such as hyaluronic acid can be used especially in the lower eyelid to correct volume deficiency that could not be addressed by blepharophylaxis alone. Autologous fat transfer into this area is also an option, with long-lasting results. Orbicularies repositioning can be used to eliminate hypotonic and herniated orbicularies muscles, soften palpebral depressions, and shorten the lower lid to cheek distance. Lower eyelid skin resurfacing can be performed with chemical peels or ablative. Conclusion. This article briefly describes the techniques of standard upper and lower eyelid blepharophylaxis. Practically, the rejuvenation of this complex anatomical area requires a combination of therapies including fat excision, repositioning or transfer, simultaneous brow or mid-face lift, and adjunctive treatment for skin resurfacing and parietal hollows. Retinal detachment happens when your retina light-sensitive layer of tissue at the back of your eye is pulled away from its normal position. Retinal detachment is a medical emergency, and early treatment is important to protect your vision. Learn more about retinal detachment. If you have a retinal detachment, you may need surgery to reattach your retina to the back of your eye within a few days. After surgery, you may need to stay in the hospital for a short time, and it might take a few weeks before your vision starts getting better. There are 3 types of surgery that doctors can do to fix a detached retina: pneumatic retinopathies and pneumatic retinopectacy. Scleral buccal vitrectomy. The type of surgery you need will depend on several things, including how much of your retina is detached and where in your eye it detached. Your doctor will talk to you about what type they recommend and about the risks and benefits of surgery. Some people may need more than one type of surgery at once. During the surgery, your doctor may also use laser or freeze treatments to repair tears or holes in your retina and help hold your retina in place after surgery. Learn more about laser surgery and freeze treatment. What is pneumatic retinopathies? In pneumatic retinopathies, your doctor will inject a smaller bubble into your eye. The bubble will push your retina back into place so your doctor can use a laser or freeze treatment to repair any holes or tears. You can usually get this surgery in your doctor's office. When you get this surgery, your doctor will put numbing medicine in your eye, insert a tiny needle into your eye, and remove a small amount of fluid. Inject a small amount of air into your eye. Use laser or freeze treatment to repair any holes or tears in your retina. You will be able to see the air bubble in your peripheral side of vision after the surgery. The bubble will disappear on its own over time. After the surgery, you will need to hold your head in a certain position for several days to keep the air bubble in the right spot. Avoid some activities like flying in an airplane, intense exercise, and heavy lifting while your eye heals. Have a follow-up visit with your doctor to make sure your eye is healing. Tell your doctor if you have any questions or concerns after surgery, including if your vision seems worse or if you have a lot of pain or swelling. What are the considerations for anesthesia during eye surgery? There are some types of eye surgery in which general anesthesia, which keeps you unconscious during the entire procedure, is either necessary or an option. However, it is more likely that you will receive monitored sedation to relax you, with a complementary regional anesthesia block to prevent you from feeling any pain. Sedation is usually provided through and if placed in a vein. Blocks are provided through an injection near the eye. Although the level of sedation varies depending on the procedure and the patient, it will most often be minimal so that you remain awake while feeling relaxed. Monitored sedation is also preferred in most cases because of the positioning of the surgeon and anesthesiologist during eye surgery. For most other surgeries, the anesthesiologist is stationed by the patient's head, with the surgeon near the middle of the body. For eye surgeries, the positions are reversed. That makes it more difficult for the anesthesiologist to intervene quickly to take corrective action if the patient has breathing difficulties, which are more apt to occur under general anesthesia. For some eye surgeries, like LASIK, the application of numbing eye drops as a topical anesthetic is enough to keep you comfortable during the procedure. Common types of eye surgery are explained below. The descriptions incorporate information provided by the National Eye Institute, National Institutes of Health. Leprosy to repair droopy eyelids. The doctor makes a small incision or incisions to remove skin and muscle and to remove or reposition fat. Cataract surgery. A cataract is a cloudy area in the lens of your eye that can make it hard to see clearly. The doctor uses tiny tools to remove the cloudy lens and replace it with an artificial lens. Corneal transplant. The doctor uses a special tool to keep your eye open while removing the damaged part of your cornea and replacing it with healthy donor tissue. Doctors can do a full-thickness corneal transplant, a penetrating keratoplasty, or a partial thickness transplant, lamellar keratoplasty. Glaucoma surgeries. For glaucoma implants, the doctor inserts a tiny tube called a shunt into the white of your eye. The tube helps extra fluid drain out of your eye, lowering your eye pressure. In a trabeculotomy, the doctor creates a tiny opening in the top of your eye, under your eyelid, to allow the extra fluid to drain. LASIK, laser anesthetic keratomyciosa. In this laser eye surgery, the doctor uses a strong beam of light, a laser, to change the shape of the cornea, which makes vision clearer for adults with nearsightedness, farsightedness, or astigmatism. Photorefractive keratectomy, commonly called prakiké, may be used as a LASIK alternative for patients with dry eyes or thin corneas. Retina surgeries. There are several procedures for repairing a damaged or detached retina, some of which may be used in combination to create small scars that will fix a tear or hole and help hold your retina in place. The doctor may apply a freezing probe, a crepotacea, or shine a laser to make a small burn, of photocoagulation. And scleral buckle surgery. The surgeon places a tiny, flexible band around the white part of your eye. The sclera. This band gently pushes the sides of your eye toward your retina to help it reattach. In pneumatic retinopathies, the doctor injects a smaller bubble into the middle of your eyeball to push your retina back. Special anesthesia note for pneumatic retinopathies patients. So if you are scheduled for any type of surgery soon after undergoing pneumatic retinopathies, it is critical that you let your anesthesiologist know about it before your surgery. Some anesthetics can interact with and change the size of the air bubble, which may remain present in your eye for 5 days to several months after your eye surgery. Eye muscle surgery. Strabismus is a condition in which the eyes don't move together as a pair, or one eye might drift in, out, up, or down. Surgery isn't the only treatment option, but when it is needed, a surgeon attempts to restore the eye muscles to a proper position by using techniques that weaken or strengthen them. This could involve removing a section of muscle or reallocating a muscle to a different point in the eye. Are there special anesthesia considerations for children? Yes, in most cases, children will receive general anesthesia. This is usually necessary because it is difficult for them to remain still under monitored sedation. Are there medical conditions that can complicate eye surgery? Yes, conditions that interfere with a patient's ability to remain in a relatively flat and still position during surgery can be problematic. Alert your anesthesiologist before surgery and consider a preoperative visit if you have a condition such as reflux, back pain, emphysema, or even a temporary cough. Discuss potential accommodations and surgery timing. What should I do to prepare for surgery? You will be told not to eat or drink for a certain period of time before surgery. Make sure you know how far in advance you need to stop eating and drinking. You should also ask which of your medicines to continue to take before the surgery and which to discontinue and when. Most eye surgeries are done on an outpatient basis, so you will go home the same day. You will not be able to take yourself home, so you will need to make arrangements for a friend or family member to provide transportation. Will I see what is happening during my surgery? Under general anesthesia, you will be unconscious and unaware of what is happening. Under monitored sedation, you will remain awake, but will not see what the surgeon is doing. The eye that is being operated on will be anesthetized and effectively unconscious. The other eye will be covered. If you receive topical anesthesia, you may see lights, colors, and shadows. You may also be given medicines to help you stay relaxed. There are several retinal diseases, but common ones include retinal detachment. If you are experiencing floaters, then retinal detachment may be occurring. If the condition is not treated quickly, it can cause permanent vision loss. Retinal terror, the symptoms are floaters and flashing lights. Diabetic eye disease is very common in people with diabetes. They are more susceptible to retinal damage and is one of the leading causes of blindness. Retinitis pigmentosa, most people with RP lose much of their sight by early adulthood. Then by age 40, they are often legally blind. Macular degeneration is an age-related problem of the retina that leads to central vision loss. The common symptoms tend to involve difficulty in focusing on fine details or blurry vision. You should get a regular retina checkup. You should get a dilated examination and complete test for retinal diseases if you wear contact lenses or glasses, have a chronic disease that increases the risk of eye problems like diabetes, family history of eye disease. When should you get retina checkup? If you are experiencing any of these unusual eye problems, get them checked right away. Vision disruptions. If you are experiencing floaters that seem to move across your eyes or flashes of light, then it's best to seek immediate attention from an eye doctor. Difficulty focusing. As suddenly you cannot focus on a specific object in your field of vision or experience blurriness when focusing on a single object. Diabetic high blood pressure. If you have conditions like diabetes or suffer from high blood pressure, then it can lead to retinal problems such as diabetic retinopathy, which is one of the leading causes of blindness. Night blindness. If you are having problems seeing clearly at night. Blurry vision. Blurry vision is the loss of sharpness, making an object appear hazy and blur. Many factors can lead to blurry vision, but it can also be a symptom of serious eye problems. Laser surgery, a photoconjugation. It is a painless and bladeless surgery procedure which uses a laser to correct retinal tearing. ROP screening. It is a procedure for detecting retinopathy in premature infants. Retinopathy can occur only in immature retinal tissues and can lead to permanent vision loss in children. ROP screening should be thoroughly done by the retina specialist doctors in order to detect damage. Green laser. It is a dye tracing procedure for ophthalmic conditions using cyanide dye and a specialized camera. The green laser can thoroughly detect eye defects such as diabetic retinopathy, vein occlusions, swelling of eyes, and tumors of eyes.